Hello, Nathalie.
How are you?
How you doing?
I'm okay, and you?
Very good. I'm just getting my background together here to look more
Ah,
professional.
okay.
Look more professional.
Okay. Let me just do same.
Your background looks fine.
Ah, but it's natural.
Well, if you want to try, we want to try. Yeah, I got to do some things. I'll be back. Okay.
Okay, no problem.
I got to make sure everything's okay. Do you have an app? Do you have the app?
No, not yet.
Okay. Okay. Won't worry. But we're trying to get that working. Okay. A lot of bugs.
Okay.
A lot of bugs. So it's not really ready to download yet, I don't think. But it's going to be so that, like, for this particular conference, for a conference like this that's live, it'll be on the front page of the app. So when you open the
Ah,
app,
okay.
you'll see this presentation, and you'll also be a link below to enter if you want.
Oh,
If you want. Now, how good is
oh,
that,
okay.
Nathalie?
Yeah, I think it's fantastic. I think
Ooh,
it's fantastic.
yeah, it'll be easy for people to jump in. It's
Oh,
not just a
sorry.
video, it's an interactive video, which is a different thing.
Oh, okay,
So you
okay,
can join if you like the discussion, or you're on the go and you say, "Oh, I want to say something about that." What
okay.
they're saying. Because I've been in conferences. I was in a conference in Jordan where someone from
Oh,
Australia was watching it.
oh,
Uh,
okay.
yeah, and
Oh,
they said, "I want to get in there," and then they get in because he was talking about a paper that he wrote. The guy from Australia,
mm-hmm.
so he wanted to comment on the paper he wrote. And the Jordan doctor loved it.
Wow. Okay, great. I just hope that we will do some how can I say some that now there's a part of medicine which is much more computerized.
Oh,
So
really?
in our countries they are still very new. They are very new. I took part
Okay.
in a seminar, and I think it's very interesting to talk about surgical TB, what you've done actually.
Okay. Yeah. Sure. Rajiv New Pain. How are you? You can unmute. I'm going to unmute you there. Hey, greetings, Ravjiv. Can you hear me?
Hello,
Okay.
doctor. Hello, doctor. I'm good. I can hear you.
Oh, good, good. Your camera's not working. I don't know if you want it on or not.
I'm on, doctor.
Oh, I can't see your face. Just
Okay, I'll try to keep
toy
it on.
toy with the photo, the video setting. There you go. Okay, there you go. How you doing?
Hello, doctor. I'm
Good.
good.
Nice to see you. Welcome, welcome.
Nice to see you.
I don't think I've seen you here before. Have you
Yeah,
been
doctor.
here? Oh, good. I'm glad you came in. You know what I said, Nathalie, on the neurosurgery cocktail. I said, don't be afraid. Just jump in on the smartphone.
Yes,
Because
doctor. You're
yeah,
right.
because yeah, people are shy, and they don't want to look bad. Maybe I don't know why, but they're kind of shy. But we had a webcast from Jordan on Wednesday, and typically after the presentation, Dr. Sabea lets he lectures, on the internet and to the audience in the auditorium, but then he'll go take the microphone and talk to us, to people on the panel that have questions or want to make comments. And so I said to Dr. Sabea, Dr. Sabea, I'm going to turn tables here. I'm going to present something to you. I'm going to show you how many people are watching. So I took him to my analytical program and showed him that he had 300 people watching him. And he didn't realize that he had. I mean, that's probably more like 500, because 300 watched on the website, but I suspect that a lot more watched on Facebook. So I would conservatively estimate like 500, 600 people were watching him, and he was like, "Whoa." Because he'll have like 40 or 50 people in the audience, and usually they don't pay attention to the internet. They don't care about the sound. They don't care about the video. But I think they'll start paying attention if that many people are watching.
Yes,
I'm not trying to make you nervous, Nathalie.
sir.
You're muted there. I got to unmute you, Natalie.
Okay, I say I usually change of environment. I travel from one city to the other because I live in a city and my parents live in another.
Okay.
So
Okay, yeah,
now I am at my parents.
Oh, okay. That's not a cell phone, right? That's a laptop.
No, that is my laptop.
Yeah.
My laptop.
Okay.
Let me just.
Okay. Yeah, I got to step away for a second.
Yeah.
So Nathalie. Oh, Dr. Khalif's here. Good. Oh, Khalif. Oh, Dr. Khalif left. Hey, Ulrich.
Hello, John.
Okay, Ulrich, you're going to run the show, right?
Yeah.
Yeah, I basically was I'm the technician. I just stay in the background. You know what I
Okay.
mean?
Yeah.
And you don't have to introduce me or anything. Just I'm like a fly in the wall.
Mm.
Because I think it's best that each channel develop its own character, and ideally I'd be a manager and not you know what I mean.
Yeah.
And that way you could you take it as your own to run it and take responsibility and stuff.
Okay.
But
Yeah.
if you have to leave, let me know. I'll just take over. Okay.
Yeah. Thanks. I'll be around. So.
Or Zolo can take over, whatever, or whatever. We'll worry about that when we get to it.
Okay.
Yeah, we did a lot of editing, man. 63 videos.
For ICRAN.
For Pakistan, yes. We got a playlist of 63 videos.
Wow.
Which I think is valuable for the developing world to be able to see all these videos from a recently concluded conference.
Yeah.
So we'll try to publicize that. There's Dylan. And Khalif, how you doing?
Hey, John.
How you been?
I am doing very well.
Great.
Okay, very good.
Yep.
So Nathalie, you
Am I too late?
I'm sorry?
Am I too late? Is the presentation over?
No, we're starting. We're about to start.
Oh, great. All right.
Nathalie, you're on mute. You're on mute.
Yeah.
Now, Nathalie, you're an intern now in Ivory Coast, or you're going to? Hey, Zolo.
Yeah, I'm a resident in
Okay.
year one.
Year one in neurosurgery.
Yeah.
Oh wow! Congratulations.
Thank you. Thank you.
Okay. Ulrich, I'll 10, 9, 8, 7, and then you after I say 1, you're live. Okay, and do what you want. But please, you know how to do it. Just introduce the panel and then run from there. Okay.
Okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, go.
Hello, everyone. It's Ulrich Sydney. I'm the president of the Association of Future African Neurosurgeons. Thanks for joining us this Saturday for yet another lecture in our series on emergency neurosurgical pathologies. Today we have 2 presentations. The first will be by Dr. Nathalie Gomsi, a first-year resident at the University of Felix Houphouët-Boigny, and the next one will be by Dewin Shishimba, who's a student from Zambia. Before we start, we're going to have presentations from all the attendees. So we'll start with Zolo. Hello, Zolo. Can you present yourself?
Hello, Ulrich. Hello, I am Zolo Ivan. I'm a CTA medical student from the University of Boya in Cameroon. I am a member of the Association of Future African Neurosurgeons. It's a pleasure being with you.
Thank you very much, Zolo. Dr. Dylan Jofak.
Hello, everyone. I'm Dr. Dylan, general practitioner from Cameroon and member of the Association of Future African Neurosurgeons. Nice to meet you all.
Thank you very much. Dr. Khalif.
My name is Khalif. I'm a 4th-year fellow in the College of Surgeons of East Central and Southern Africa, currently at Nairobi at the University Hospital, and glad to be here.
Thank you so much, and we are glad to have you. Always nice to have our seniors around. Dr. Stefan Gembu, can you present yourself, please?
General practitioner. Oops. Everybody know how you hear me? Hello?
We didn't get that, sorry.
Okay. I'm Stefan Gembu, medical practitioner from Cameroon, member of IFEN. Glad to be with you.
Okay, thank you so much. Rajiv Nupane.
Hello, doctor. I'm doctor from Nepal, recently practicing in the as a neurosurgeon medical officer, and I'm struggling for the to practice, get the training in the neurosurgery in the UK.
Oh, we're glad to count you among us. Dewin Sishimba, can you present yourself, please?
I'm a medical student from Copperbelt University, Zambia. I'm glad to be here. Thank you very much.
We're glad to have you as well. And finally, Dr. Natalie Gomsi will present herself, and she will start her presentation right away. Thanks.
Thank you, Sydney. Hello, everyone. I am Natalie Gomsi. I'm a medical doctor. I'm a year one resident in neurosurgery in Abidjan, University of Abidjan. Today, we are going to talk about extracranial, extraaxial hemorrhages. Extraaxial hemorrhages. Extraaxial hemorrhages. And in order to talk better about it, we'll follow this plan. After an introduction, we shall talk about extradural hematomas, acute subdural hematomas, subarachnoid hemorrhage, a brief talk on subarachnoid hemorrhage, and then we shall conclude by sorry. We should first know that intracranial hemorrhages are hemorrhages within the cranium. They are divided into two different kinds of hemorrhage. We have the intraaxial hemorrhages, also known as intracerebral hemorrhages, which are hemorrhages found within the parenchyma or within the in the intraventricular space. We also have extracranial hemorrhages, which are hemorrhages which are found within the cranium, but outside the parenchyma of the brain. They are usually found within the meningeal spaces. We have the extradural hemorrhages, the subdural hemorrhages, and the subarachnoid hemorrhages. The brain is protected by protected inside the skull by three separate layers. The meninges. We have from the innermost layer to the outermost layer, we have the pia mater, which lies just on the parenchyma of the brain. We have the arachnoid hematoma here in purple color, and then we have the dural matter. The dural matter is divided into two parts. We have one part which is which lies directly on the periostrum, that's the skull, and we have a second part just underneath it, the meningeal dural matter. These layers define three potential spaces for blood collection. We have the epidural space, which is found between the skull and the dural matter, that's the periostal dural matter. We have the subdural space, which is found between the dural matter and the arachnoid layer. And then we have the subarachnoid layer, which is found between the arachnoid matter and the pia mater. We shall first start by talking about extradural hematomas. These are collections of blood which are found between the potential space that exists between the inner table of the skull and the dural matter. That's the periostral layer of the dural matter. The extension of the hematoma is usually limited by the suture lines, as you can see here. The hematoma is being limited by the sagittal suture on top and then the squamous suture beneath. This is due to the light attachment of the dura to these different locations, as sutures. It represents approximately 2% of all brain injuries, and amongst which 5% to 15% of patients with fatal head injuries. It can be found in an acute form, a subacute, and a chronic form. It occurs mostly in young adults and are very rare in children less than 2 years due to the plasticity of the immature skull of these children. They are also mostly found in patients less found in patients greater than 60 years old due to the adherence of the dura mater to the underlying bone. The incidence of delayed extradural hematomas following following initial negative CT scan is also reported in 10 to 30% of cases. How are these extradural hematomas formed? When we have a trauma, there's a brief linear contact force to the skull that causes a separation between the parietal layer of the dura mater and from the bone. This also leads to a disruption of the interposed vessels due to shearing stress. In 85 to 95%, we will find of these cases, we will find a patient with a fracture of the underlying skull. Chronic and delayed manifestation may also occur. That is when there's a venous source involved. The middle meningeal hematomas arises from injuries to the middle meningeal artery in over 50% of the patients. We can also find an injury of the middle meningeal veins, diploic veins, and torn dural venous sinus. As we said earlier, a fracture of the temporoparietal region may lead to middle meningeal artery, to a rupture or an injury of the middle meningeal artery, which will lead to, which is the main cause of extradural hematoma. Though we can also find other locations, such as an injury in the frontal bone will lead to an anterior ethmoidal artery injury, bleeding. An occipital injury may lead to a transverse or sigmoid sinus bleeding, and we can have a superior sagittal sinus bleeding if the trauma is at the vertex. The main clinical presentations of the extradural hematoma has 3 phases. We have a brief post-traumatic loss of consciousness for the initial impact. Secondly, the patient will find himself in a lucid interval for several hours. This interval is an interval where the patient doesn't complain of any. The patient doesn't complain of any symptom, neurological symptom of deficit. And then secondly, the patient will find himself with a contralateral deficit, ipsilateral pupillary dilation due to the mass effect from the hematoma. Other clinical presentations could be seizures, elevated CSF pressure, ipsilateral hemiparesis. It could also have what they call a Kenohan knot phenomenon. To simply explain, the Kenohan knot phenomenon is a situation where the patient presents ipsilateral symptoms, ipsilateral deficit due to the compression to the lesion, due to the compression of the hematoma on the contralateral parenchymal brain, to the compression of the contralateral brain, parenchymal brain on the skull. On the other side, the patient will have first localizing sign. We have a patient who has a right, for example, a right extradural hematoma, and we find himself having a right hemiparesis. It should be noted also that in pediatrics, and a drop of 10% of the hematocrit after admission could also we should suspect extradural hematoma. The radiological diagnosis is usually the exam used to determine how the surgical indication or non-surgical indication, or in fact, to determine the type of management to be used. It is usually easier to see. That's, we have a patient with a biconvex here. Well, for example, here we have a biconvex or lenticular shaped hyperdensity, homogeneous hyperdensity that does not crosses the suture. Here we have the sagittal suture and it doesn't crosses the squamous suture beneath. The management of extradural hematoma could be either conservative or surgical. The main indications, surgical indications, are a volume of hematoma greater than 30 centimeters cube, a volume of hematoma greater than 30 centimeters cube with a thickness of 15 millimeters or a midline shift of more than 5 millimeters. If this patient doesn't present all these criteria, but has signs of herniation, cardiorespiratory abnormalities, azochoria, and has a severe traumatic brain injury, then the patient should be operated. The techniques of surgery is usually a simple craniotomy with the evacuation of the hematoma. Volume of less than 30 centimeters cube. Thickness of thickness of the hematoma less than 15 millimeters, and a midline shift less than 5 millimeters. A non-severe brain injury and no focal neurologic deficit can be managed non-surgically if with serial CT scans being done and a close neurosurgical observation in a neurosurgical center. Secondly, we shall talk about acute subdural hematomas. Acute subdural hematomas is a collection of blood between the inner layer of the dural, as you can see, an inner layer of the dural matter, but it is external to the brain and to the arachnoid. It is the most common traumatic intracranial lesion, and it occurs in 29% of traumatic brain injuries. It is motor vehicle accident is the main cause in young patients. Here we have a high magnitude, during the trauma, we have a high magnitude, magnitude of impact damage as opposed to secondary damage. It is usually much higher in acute subdural hematoma than epidural hematomas. Which generally makes this lesion more lethal than epidural hematomas. It is usually also accompanied with other underlying brain injuries such as diffuse axonal lesions. The mechanism of the injuries varies between the age groups. Most subdural hematomas are caused by vehicle-related accident, as we said earlier, but it could also be caused by force or assault. The two common causes of traumatic acute subdural hematomas are accumulation. Firstly, accumulation around the parenchymal laceration. There is usually a severe underlying primary injury. In these cases, the patient will present with no lucid interval. Focal signs usually occur later and are less prominent than epidural hematomas. It certainly could also be caused by surface or bridging vessels torn from cerebral deceleration and acceleration during violent hand motion. Yeah, with this etiology, primary brain damage may be less severe. A lucid interval may occur with later rapid deterioration. As for its clinical presentation, they are usually severe, with the patient finding himself with a low Glasgow Coma scale. The patient is usually having a severe traumatic brain injuries. The patient may also have associated lesions such as diffuse axonal lesions or brain herniation. As you can see, we have already a brain herniation. There's a midline shift, an important midline shift. On enhanced CT scan is also the exam of choice. On an enhanced CT scan, we had a patient of 30 years who had a motorbike accident. And you can see this lesion, and on this enhanced CT scan, a crescent-shaped homogeneous hyperdense extraaxial collection. It doesn't have any limits. It is not limited by any sutures, contrarily to the epidural hematoma, but it is limited by the dural reflection that's in the interfacing space, for example. MRI could also be carried out, but it is not the exam of choice in front of this patient because MRI really takes time. It really takes much more time to be carried out than the CT scan. So, but it's not the exam of choice. The management could also, just as epidural hematoma, it could also be surgical and non-surgical. There are surgical indications. One of the surgical indications, which is an absolute indication, is a thickness of the hematoma greater than 1 centimeter or midline shift greater than 5 centimeters, regardless of the Glasgow Coma scale. A patient which presents itself, though other indications which are relative indications could be taken, such as patient who present himself with a severe traumatic brain injury with lack of the ability to localize on motor response. He should undergo ICP monitoring. Patients which comes with a brain injury, a severe brain injury with the thickness of the hematoma less than 1 centimeter and midline shift less than 5 millimeters should undergo surgical evacuation if the Glasgow Coma Scale decreases by 2 points, if there's abnormal pupillary examination, or there is sustained increase in intracranial pressure above 20 millimeters despite medical therapies. Here, I'm going to elaborate. This is a patient we received, the patient we received with, he had a right subdural, acute subdural hematoma following a car accident. He was 32 years old. So when the patient arrived, he was at a global Glasgow outcome scale, Glasgow Coma scale of 8. So emergency CT scan was done, which found this hematoma, this voluminous and large hematoma, subdural hematoma, panhemispheric hematoma. So what do? We carried urgently the patient to the theater where we did an osteoplastic craniotomy using a jiggly saw. Using a jiggly saw, as you can see, after a burr hose, we used a jiggly saw. And then secondly, we did a cruciform incision on the dura mater, and then we started draining the and washing of the. Oh, sorry, this is supposed to be. Let me stop sharing. Please let me just put it back. It's supposed to be a video. Oh. Stop. Okay, let me just no. Okay. So I don't know if everybody can see.
Yes, we can see.
Yes, we can.
Thank you. So that's the hematoma. It was really a voluminous hematoma that we removed at emergency. It's just that maybe I should have taken a better video of around the hall so that you can see in which conditions we operate these patients. We don't waste time. Usually our emergency unit is not really, how can I say, appropriate, but everywhere we can be, we can do this surgery. Even general practitioners are taught to do this surgery since we don't have neurosurgeons everywhere in Cameroon. So if he has the appropriate equipment, he can also do this. After that, we wash the hematoma with saline solution. This is so that we can remove all the products of degradation of red blood cells of blood. It won't. It was bleeding. We have this cortical artery, which was bleeding. So after doing that, we will try to cauterize the cortical artery with the electric destroy. Then lastly, I won't really talk much about this because it was already done by Dr. Gampe, I think 2 weeks ago. We shall talk about subarachnoid hemorrhages. These are hemorrhages where there is a lesion of vessels found between, as we said earlier, between the arachnoid space layer and the pia mater. The main causes are the stomach is the main cause of subarachnoid hemorrhage, but it could also be spontaneous, where aneurysms, ruptured aneurysms represent 75 to 80% of this hemorrhage. We should also note that this subarachnoid hemorrhage incidence varies worldwide, ranges from 1.1 to 82.3 per 100 persons per year. And it is lowest in the Middle East and highest in Japan, Australia, and Scandinavia, especially in Finland. The sex ratio is 1.6 females to 1 male. Its clinical diagnosis, we have in the clinical presentation, we have 3 main presentations. The patient may present himself at the hospital with a thunderclap headache, a sentinel headache, that's the headache which occurred 6 to 8 weeks earlier, and which was spontaneous, that is, it was coming out spontaneously and being resolved spontaneously. Or he may also present with sudden death. There are usually no focal signs, neurological signs due to the, except if there is a complication. The patient is usually comes with signs of meningeal irritation. Thus, we have the patient with head stiffness, neck stiffness. We have the Brudzinski sign, the Brudzinski sign, and the Koenig sign. The patient may also present himself with seizures. When the patient presents with these symptoms, usually what we do is we do a lumbar puncture to look at the quality of the macroscopic quality of the CSF, of the cerebrospinal fluid. It could be xanthochromic, that's this color. It could also be very bloody, which really signs subarachnoid hematoma, or could also have this pinkish color. When it is xanthochromic, it is the product is hemoglobin. That's the degradation. The degradation of this due to the presence of bilirubin in the, which is a product of degradation of hemoglobin from the red blood cells. We can also have different clinical presentations depending on the anatomic situation of the rupture, of the aneurysm rupture. Patients who present themselves with third nerve palsy usually indicate an aneurysm at the junction of the posterior communicant artery and the internal cerebral carotid artery. If a patient presents himself with transient paralysis of one or both lower limbs, it suggests an aneurysm, a ruptured aneurysms of the anterior communicant aneurysms at the paracentral lobula. If a patient presents himself a hemiparalysis with hemiparalysis of aphasia, it usually suggests an aneurysm of the first major bifurcation of the middle cerebral artery. The patient also may present himself with blindness, sudden blindness, which usually signs an aneurysm that lies in the anteromedial part of the circle of Willis. The WFNS came out with a classification which helps, a clinical classification grading, which helps in the prognostics of patients with subarachnoid hemorrhage. This clinical classification, prognostic classification, depends on the Glasgow Coma Scale and the motor deficit. Patients with grade 1 usually have Glasgow Coma Scales, which is at 15, without any motor deficits. Grade 2, the patient will present with a Glasgow Coma Scale between 14 and 13 without hemiparesis, without a motor deficit. As for grade 3, the patient will present himself with a Glasgow Coma Scale between 13 and 14, but we have either motor deficits or nerve palsies. A grade 4, the patient will present with a Glasgow Coma Scale between 7 and 12 without any motor deficits. While grade 5 will be patient between 6 and 3, with or without, regardless of for grade 4, it's a patient who will present with a Glasgow Coma Scale between 7 and 12, regardless of any motor deficit. While grade 5 is a patient who presents himself with a Glasgow Coma Scale between 6 and 3. The CT scan, on exam CT scan, remains the exam of choice for this pathology. It has a 98% sensitivity. As we can see here, we have a spontaneous hyperdensity of the subarachnoid space. That is diffuse, everywhere is being infiltrated. And Fisher came out with a prognostic image classification. This classification will help in the decision of management. It depends on the the thickness of the subarachnoid hemorrhage associated or not with interventricular hemorrhage. For example, patients who have a 0 grade are patients who do not have, where there is no subarachnoid hemorrhage seen on CT scan nor interventricular hemorrhage, while those with grade 4 are patients who have a thick subarachnoid hemorrhage with intraventricular hemorrhage in both lateral and lateral ventricles. So this is a hemorrhage, subarachnoid hemorrhage in the middle cerebral artery territory. Other diagnosis could be done if a patient presents himself with a grade 0, but there are clinical signs which are falsely suspicious of subarachnoid hemorrhage. We can do a puncture of CSF, as I said earlier, where red blood cell counts will be up to 1 million per millimeters cube. It will have a xanthochromic color due to the presence of bilirubin in the CSF. Vessel angiography could also be done, which will localize and define the anatomic details of the aneurysms. Sorry. Yeah. Subarachnoid hemorrhages are usually accompanied with 4 major complications. These 4 major complications are usually the cause of delayed neurological deficit. As a patient presents with secondary neurological deficit, which he didn't have at the beginning. We have firstly hydrocephalus, which is caused by the obstruction of CSF flow by clotted blood. It can occur either early, where the surgical management will differ. If it occurs early, we will do an external ventricular derivation. While if it occurs late, we can do a ventricular peritoneal shunt. But while doing this drainage, care should be taken because a reduction in intracranial pressure can also increase the risk of rebleeding. As for rebleeding, it usually occurs within the first 24 hours. Up to 20% of patients rebleed within 2 weeks. The main preventive measure in control of blood pressure is the control of blood pressure by beta blockers or calcium channel antagonists. An alternative early clipping of the aneurysm allows hypertensive and hypervolemic therapy to prevent vasospasm. The third is the vasospasm itself. What happens is when there's a rupture of an aneurysm, the blood liberated. There are products in the vessels which will go and which are vasoconstrictive. It will cause a vasoconstriction of the underlying vessel where the blood will find itself. So the patient may have neurologic deficits from cerebral ischemia. And usually vasospasm occurs between the 4th and the 12th day after the subarachnoid hemorrhage. The main treatment used here, and which has clinically proved that improved the outcome of these patients, is nimodipine, a calcium channel antagonist. This patient will also find himself with a hypothalamic dysfunction. This is caused by excessive sympathetic stimulations. This sympathetic stimulation may also lead to myocardial ischemia, or we have a labile blood pressure. Hyponatremia is frequently found in these patients. Hyponatremia is also frequently found in this patient due to salt wasting or inappropriate secretion of antidiuretic hormone. This patient also may be subjected to pulmonary edema, which could be neurogenic or non-neurogenic. As for its management, the main aim during the management of subarachnoid hematoma is to protect the airways, to manage the blood pressure in order to prevent an elevation of the ICP, to prevent rebleeding, to manage the vasospasm, to treat hydrocephalus, the complications such as hydrocephalus and hyponatremia, and to prevent pulmonary embolus. These patients are usually advised to have bed rest in a quiet place. and they are being put on stool softeners. This to prevent bleeding by the increase of the Valsalva maneuver, which may also increase the intracranial pressure. The adequate hydration is necessary to avoid a decrease in blood volume, predisposing to brain ischemia. Mannitol is used to control the ICP. As for the blood pressure, as we said earlier, inhibitors, calcium beta blockers or calcium channel inhibitors such as nicardipine can be used to maintain the cerebral perfusion. The cerebral in order to maintain the cerebral pressure, the cerebral perfusion pressure at 60 to 70 millimeters mercury. Phenytoin is usually used to prevent seizures, which are really frequent to these patients. As for the management of vasospasms, these patients are usually put on 60 milligrams oral 60 milligrams of every 4 hours of nimodipine. We should note that no situation should prevent the administration of this nimodipine. If the patient can't swallow, we can put the patient nasogastric tube so that we can send nimodipine through the nasogastric tube. Now, finally, talking about the interventional treatment, after the patient has been stable, we can now proceed to surgical repair with a clip, endoscopic repair with platinum coils. As for me, I've never seen this repair as endoscopic repair, but I'm a little bit used to a clip. The use of a clip, that is through Professor Ipe and even locally in our country. So this is just a summary of the management of the different complications that we can have. In conclusion, what I'll say is that extracranial hemorrhages are neurosurgical emergencies. The lucid interval constitutes a main but not pathognomonic clinical characteristics of extradural hematomas. Acute subdural hematomas has a higher mortality rate than extradural hematomas, and always think of subarachnoid hematoma in front of a thunderclap headache. The management of extracranial hemorrhages is usually multidisciplinary, involving the neurosurgeon, the anesthetist, the cardiologist, and the other re-educating personnel. The surgery indications usually depends on the Glasgow Coma scale, the thickness of the hematoma, the midline shifts, and the secondary monitoring of intracranial pressure. I thank you for your attention.
Thank you so much, Dr. Natalie. That was a great presentation. We'll now open the floor for anyone who has questions or comments.
Hi.
Hi,
great. Hi, great presentation, Dr. Natalie. Really very extensive. I did every part of it. Great presentation.
Thanks, dear. Thanks, Dylan.
So you briefly mentioned the other modalities of treatment for subarachnoid hemorrhages. So in cases of aneurysms, like you rightly said, you can use clips, and there are other technologies available today besides clips. You have, obviously you spoke about the coils, but you can equally have flow diverters. The concept behind flow diverters is you're trying to modify the rheology, the flow of blood in the aneurysm. So you're going to slow down the flow of blood, and when you slow down the flow of blood, you have stagnation, and then you can equally have another way you can use these devices is to engender, I would say, so to promote reconstruction at the level of the vessel wall. So you can equally do some reconstruction of the wall, and this will obviously take more time. So if the risk is more imminent, then you're more likely to go with, it's better indicated for you to go with clipping than coiling. So there's this discussion nowadays about clipping versus coiling, and I think it's the perspective is different from whether you are in a high-income country or whether you're in a low and middle-income country. A lot of studies have come up with superiority of endovascular techniques, that's coiling, flow diverters, for example, versus open vascular, which is the clipping technique. And a few people like Professor Ibshiran have argued that the problem with endovascular technique is they are very expensive. In an LMIC setting, they are not necessarily the most adequate or indicated modalities. Other people argue that you can have endovascular suits, not just for neurosurgery, but for cardiovascular as well. So that when you have those two, for example, working together with peripheral surgeons as well, then you can bring down the cost and you can be using those suits quite often. So it's interesting. In the US, they train neurosurgeons to be dual surgeons. They do endovascular and open vascular. So you have some surgeons, for example, at Brigham here at Harvard, that's a lot of the vascular surgeons do both. They do both endovascular and open vascular. It's very interesting because they are the same people doing it. So they can give you the reasons why they do one and not the other. But in other countries, usually it's the interventional radiologist that does the endovascular, and then you've got the neurosurgeon doing the open vascular. And in that sense, you might not necessarily have the best of, you have a conflict of interest usually. That's the best way to put it. And there was a really good conference where we had the older guard of vascular who have been proning and promoting clipping versus coiling. And the problem today is most of those trained in the US are trained mostly to do endovascular technique. And the clipping cases are really the complicated cases, like really complicated. And so you get the really experienced people doing the really complicated cases in such a way that when you finish your training, you've not done that many cases of clipping. So you probably do, the first time you fall on a case of clipping will be the most complicated thing you can imagine. And there's this story about Spetzler, who speaks about clipology, Michael Lawton and Spetzler, they speak about clipology, and having us, the younger generation, train more and more on in the lab to have that skill. And it's interesting, it's really good that you had this, you brought up all these points. And I think this is where us, as the future African neurosurgeons, we have to think about these things. Like, where do we see neurosurgery in 10 years, in 20 years? Are we going to be doing the same things as the US or the rest of the Western world? Personally, I don't think so. And I think we need to know these things and take the right decision. That was the comment I was going to add there. I think Dr. Khalif has something to say here.
Yeah, that's a very interesting discussion you're having, Ulrich. The issue of subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, is a very, very underdiagnosed and undertreated problem in Africa.
Yeah.
Let's take, for example, in Kenya. Our last census, which came out last month, shows that we have 47 million Kenyans in this country. So if you take the general incidence of aneurysms, that is around 1 to 2% of the population are walking around with aneurysms. So that gives us around 470,000 Kenyans with aneurysms out of the 47 million. And then of that, 1% will rupture every year. So in Kenya, according to the statistics of all the major studies that did population studies on aneurysms, we have at least 4,700 ruptured aneurysms in Kenya. Yes, how many of those are diagnosed and treated? Less than 500 in all major neurosurgical centers, which are around 5 in this country. we don't even see 500 cases, which means these patients go to our hospital, they complain of severe headache, somebody treats them for malaria or meningitis or some funny things, they go back home and they die. So what kills these patients? Before I come to the discussion that Mr. was leading, what kills these patients? The first thing that kills them is rebleed. They bleed within 3 days. The first time, the first rupture, 15% of the patients will die on the spot. They don't make it to the hospital. So that gives you around 85%. Of this 85%, another 30% will die within 4 weeks of other complications. If they survive pre-rupture or rebleed, then what kills them is severe vasospasm, hydrocephalus, the other complications of ICU care, of pneumonia, and DVT and stuff like that. So this is a very, very high mortality, morbidity disease that is underdiagnosed in this region of the world. So as young people who are training with these things, we need to be aware of it. Because one of the things that is happening is even the doctors, the general doctors are not, they are not aware of what is happening with these patients. They are not diagnosed on time. Nobody does a CT scan. If you do a CT scan and you find that the CT scan is normal, you should do a lumbar puncture to rule out subarachnoid hemorrhage. That rarely happens, at least in Kenya. And I'm thinking that's the same for the entire continent. So these patients, what kills them most is rebleed. So that discussion of do we need to coil them or do we need to clip them is a little advanced for us as of now. Whatever form of treatment you have, prevent the rebleed. That is the most important thing. If you can clip and you cannot coil, please do the clipping. If you are fortunate enough, like the center in which I am, we're doing both coiling and clipping. We have 70% of our patients are coiled and 30% are clipped. We have a neurosurgeon from South Africa who's very, very experienced in both ways. So very fortunate, but we don't get those many patients because we don't get the referral on time. Patients die. So the most important thing is not whether to use clipping or coiling for us as Africans. That discussion, we'll have it later when at least we have both options. The most important thing is at least treat these patients. Take them to theater. Don't wait for 2 weeks. Clip the aneurysm. That will save lives. That's the most important thing. And the second part of which one is superior, clipping and coiling, that question has already been answered. It's clear. Everybody knows that coiling is superior to clipping, but unfortunately, it is capital intensive. You need the infrastructure, you need the personnel, you need a lot of things. But that question has already been answered in several studies, in the ISAT, in Barrow study, with some of these and many other studies that had to be stopped because they found out that the modified Rankine scale of patients who are coiled was much, much superior to patients who are clipped. So that discussion we're going to have as Africans, as you're saying, our main priority is to learn both ways. We don't have that luxury of guys in where you are, where Sydney is right now, that you can choose which one do you have. Do you want to, is this aneurysm coilable or is it clippable? That is not available in many African countries. So the most important thing is have both ways. If you are lucky and you have the services, go ahead and do most of the coiling. But if you don't sit on these patients. Don't wait for the old teaching of like you have to wait for 2 weeks until the vasospasm clears. No, they will die of rebleed. Clip the aneurysm. That's what I'm going to say. But the other thing that is important is that it's not just the surgery. The post-op care is also intensive, and that's another thing that we need to worry, critical care for these patients. And as you've seen, their outcomes is not as good as other patients. They get profound cognitive decline. If you do their mock score in 1 year, these guys they can dress, they can eat, they can walk around, but they are completely changed. They can't do any high functioning job. So it's a devastating disease. It's actually worse than subdural hematoma. It's worse than epidural hematoma. It's worse than any other hematoma of the brain that we can think of. That's what I'll say.
Yes. Thank you so much, Dr. Khalif. You hit all the points there, and adding to this, I think one of the biggest thing with us in this group and the platform is that we need to build a community and learn what others do, because there's usually this bad way of thinking in that certain things are only done in the US, for example, or in Europe. If you know people around Africa, then you find out, for example, that on the continent, some people are doing, say, endovascular and clipping, and you can travel, speak with these people, ask them how they do it, how they arrange, because there's certain things we've all noticed. There's certain things beyond the neurosurgery. There are a lot of things we need to figure out for ourselves. When you go and train, you come back, usually you have this department where you're really high up. You have to do administration, you have to do management, and you still have to be able to operate. Or sometimes you come and you're the only person. You're the one reading the scans. You're the one doing the ICU guidelines. So it means the neurosurgeon, the African neurosurgeon for tomorrow, is not just the person who's apt in the OR. You can do the greatest intervention ever, but if you don't have the right ICU, you get really terrible results. So that's why we need to engage. We need to get more people, to learn these things, to understand these things, like the disease, like Dr. Khalif said. You should be able to recognize these things. And that means your classmates, for example, for those who are medical students, even if people don't recognize this, you being here, you should be like, I think this might be a subarachnoid hemorrhage. That's where we need to start. We need to start speaking about this, recognizing it, because most people think this is a disease that exists just in like fancy books, but it's not the case. People are dying from it. We just need to be able to recognize it. Thank you so much, Dr. Natalie. If anyone wants to comment again, we still have 11 minutes before we start the next presentation.
Yes, hello everyone.
Hello.
Yes, I have this question. Yes, I have this question, like, because when Dr. Natalie was presenting, she spoke about sentinel headache, and if you
Sorry, Zolo. If you're hearing me, your connection is not great. So if you can cut your video feed, then maybe we'll be able to hear you. Yeah, I think he's disconnected. If anyone else has a question, while we'll wait for him to come back.
Yeah, sorry, I missed that. The sentinel headache thing that I was asking about. It usually happens within 2 weeks before main rupture. It's a telltale sign of bad things about to happen. Unfortunately, everybody misses it. Patient complains of funny, severe headache that goes away within. That means that the aneurysm has leaked just a little bit, That's just a bad sign. It means that it's going to rupture. So if you have a patient who is known to have an aneurysm that has not ruptured, and then they present with such, if they present with such, sorry, let me just connect my. If the patient presents with such then that aneurysm needs to be taken care of.
Okay, then I just wanted to ask how will you know? Because the real truth is that us here, we don't really do exams just like that. In Africa in general, I don't know how it's in Kenya, but here in Cameroon, when you ask the patient to do an exam, go and do an MRI, go and do this, the argument, he argues with you. You have what you call the syndrome of argument with the doctor. That's the patient knows better his pathology than you. When you tell somebody that he has this headache that is just transient, that comes and then goes, go and do an angio scan, go and do this, the patient will just like, that doctor is not a good doctor. That's the first thing.
So actually, what we need to do is you just need to do the right thing. If somebody presents with the worst headache of their life, just tell them that your life might be in danger. You just go do a CT scan. It's $50, $60, $80, $100. It is going to help me treat you. So if they refuse, then that person has made a conscious decision of not following your instructions. But you have to tell them. You have to tell them if this is the worst headache of your life, it might be something called ruptured aneurysm, and we need to test you for that. Yeah.
Is that
I know
I'm talking about the.
And then the other thing is why that happens mostly patients are paying out of pocket. And that is a problem with most African countries. We don't have a universal healthcare.
Yeah, I think the network is not great. Well, I'm sure he'll be back shortly.
Can you hear me?
Oh, now we can hear you. Yes. Oh, now.
Okay.
Yeah, so
I was just asking myself, I said, yeah, that in our countries, we don't have enough neurosurgeons to cover the whole territory. And so what do you think about the idea of general practitioners being formed to evacuate hematomas, intracranial hematomas?
So this is it's a fantastic question. There are a few points that have been raised here, and they go beyond the simple practice of neurosurgery. And this is what we call today global neurosurgery. Global neurosurgery is about bringing access to people, access of neurosurgical care to people that need it. This access has to be affordable. This access has to be timely. This access has to be safe. So how do we make sure it's affordable? That's what we're mentioning. People paying out of pockets. We cannot have people paying out of pocket because, well, one thing, health costs money. Someone has to pay for it. And unfortunately, health, like unlike many other things, health happens when you don't expect it. The truth is, no one, only, or we'll say only a few people on this earth will be able to take care of their health expenditures at any time.
Yeah.
Few people have money saved somewhere. And this is why everywhere people get insurance, because when health hits, then you have to pay a lot of money. And in this insurance, the objective now is to have universal health coverage. So us as future neurosurgeons, we have to get involved in these talks. We have to make sure that when they define the universal health coverage, because the problem is not just to say we have universal health coverage. In the universal health coverage, they will not cover everything. They will choose a few diseases, a few interventions. So if neurosurgeons are not there when they're choosing the diseases and the interventions, then you will have everything, but no neurosurgery. And what we need to understand is we need to propose those conditions for which, for example, a lot of people are touched, or the few people who are affected by the diseases are severely hit. They might be dead, like is the case with subarachnoid hemorrhage, or maybe they're just disabled. So those are the ones we need to choose, because everyone will be proposing, like rheumatology will be like, oh, we need you to cover this. Cardiology, it's general surgery. Yeah. Neurosurgery has to be able to be like, these are the diseases we need you to cover. And we know, for example, traumatic brain injury, like that's the big thing. Okay, so even if we had to choose just one, traumatic brain injury, if you're talking about pediatric neurosurgery, then hydrocephalus. And that's how you go. You keep going and you choose one, and then you propose. That's for the affordability. For the timeliness, people have to have geographical access to this care. So it doesn't matter if you have this one center in a country which does fantastic neurosurgery, but it is, say, 16 hours by road from the furthest person. Then the furthest person, if he has a disease that necessitates to be taken care in time, will have difficulties getting there. So that's one thing. The other access is about the reference system. And this is where we have problems. In most of our countries, any patient can get up and just go to a reference hospital.
Yeah.
People don't go from primary healthcare to the reference hospital. So at the end of the day, what you have is the reference hospital has so many patients way too many patients for itself, while the primary health centers don't have that many patients, or don't even have patients at all. So if we need to work in each of our countries, you need to understand how does the reference system work now, and you need to be there and advocating that we all need to set up a good reference systems. People should not just go to the provincial hospital or to the regional hospital. That's not how things should work. If you keep doing that, then you have your neurosurgeon spending time with someone who has a headache because they didn't sleep because they had to take an examination, instead of spending time with someone who had a headache because he's having a subarachnoid hemorrhage. So that's one thing we all need to work towards. We have to work so that we set up this reference system, and that means even ourselves, even among our colleagues, people need to understand when to send a patient to the next level and not delay the patient at the level. So you have a hospital that can take care of a subarachnoid hemorrhage and you're keeping the patient for 12, 21 days. If you can't do anything for the patient, let the patient go and tell them where they can meet people. But equally ourselves, it's not because you're a neurosurgery resident or a neurosurgeon that you shouldn't be talking to other people. People should know you. People should have your number. People should be able to access you. So someone might be a primary care physician in a remote village, and he should be able to be like, hey, doc, I have this. And from what you hear, you're like, I think this patient should come straight up and I have a bed for him, for example. So if a patient is living 300 kilometers away to come to your hospital, and we all know this, you send a patient to the capital city usually, and then they get there, there's no bed. Or you send a patient, they get there, there's no bed in the ICU, so he cannot go into the OR. We need to, even if we can't get to that highest level of organization, we can do these things. You can have WhatsApp groups where you're speaking, neurologists are speaking with neurosurgeons. A neurologist is like, we have this patient, can you take him? And vice versa. So that's the other thing. We spoke about affordability, we spoke about timeliness, now we have to speak about safety. If what you're suggesting is being done and is being published, and in neurosurgery, there's the papers that have been published by Dr. Faith Robertson, who is currently an PGY1 resident at Massachusetts Grand Hospital, one of the Harvard hospitals. So Dr. Robertson studied task shifting and task sharing. I'll share the papers in the WhatsApp group. You can read about this. And she basically did a survey on people's impressions. Task shifting will happen, and it is happening. We all know that. The problem is, how safe is it? It will happen, and it is happening because you cannot take a neurosurgeon who's trained for that many years and send them, for example, to the most remote villages. One, they don't have access to that many patients. Two, they don't have the resources, so they will have to stay in the bigger centers. So if we're talking about accessibility, then those who are remote have to be able to get some care, especially when it is within a time frame. So you have certain diseases like stroke. Stroke, you have a time period during which you have to do something. Traumatic brain injury, you have a time period, a golden hour during which you have to do something. And if you don't do something, then the patient starts losing points. So we need people like general practitioners or general surgeons to do these operations. Now the question is, how do we train them to do it the right way? But equally, the other question is, how do you train them so that they understand what they can do and what they cannot do? Because that's usually the problem, right? Let's take obstetrics. We all know this. In most of our villages, you know of people giving birth but nurses are helping them and all that. But we've all gone through OBGYN. There are certain births that are really easy, and there's some of them that just get complicated really quickly. You just have postpartum hemorrhage, and the next thing you know, you need a gynecologist. So you need people to recognize that I can do this and I cannot do this. And if I get to this limit, I cannot do anything, I need to send the patient off. So all these things, we have to define them. So the idea is out there, the idea is being studied, and I invite everyone to participate in this discussion.
Okay.
Any other comments? Okay, so we're going to start our second presentation. Once again, we'll present ourselves all together.
John, so that he can stop the recording of this one.
Yes.
Go ahead with the win.
Yeah, he can always edit it. So we'll represent ourselves. Let's start with Dr. Natalie. Can you present yourself, please?
Hello, everyone. I am Natalie Gomsi. I am a PG Year 1 student in University of Abidjan, and I am also a member of AFN.
Okay, thank you very much. Dr. Dylan Jofak.
Hello, everyone. I am Dr. Dylan Jofak, a general practitioner from Cameroon and member of the Association of Future African Neurosurgeons. Nice to meet you all.
Thank you very much. Asen Nyalunja, can you present yourself, please?
Hello, everyone.
Hi.
Hello, everyone.
Hi.
I'm Arsen Daniel. I'm from GRC. I'm a medical student in the last year. I'm aspiring to be a neurosurgeon and a member of AFAN. It is a pleasure to meet all of you.
Yeah, it's a pleasure as well. Thank you so much. Zolo Ivan.
Hello, everyone. I am Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon, and I'm a member of the Association of Future African Neurosurgeons. It's a pleasure being with you.
Okay. Dr. Rajiv, if you're still here, can you present yourself? You're muted. Okay.
I'm Dr. Rajiv Neupane. I'm from Nepal. I'm a member of the future AFAN, and I'm recently practicing in the Department of Neurosurgery in Nepal as a senior house officer, and I'm interested in the neurosurgery. It's all my pleasure to meet you all. Hi, everybody.
Hi. Thank you so much. So I'm the last one. I'm Ulrich Sidney. I am the president of the Association of Future African Neurosurgeons, and I am currently a research associate at Programming Global Surgery and Social Change at Harvard Medical School. We'll go on with our presentation. Our presenter today is Darwin Sichimba. Darwin, can you present yourself and start your presentation? Darwin, can you please present yourself?
Hello, everyone.
Start your presentation.
Okay, I'm Darwin Sichimba. I'm a medical student from Copperbelt University, Zambia, and I'm interested in neurosurgery. And I'm a member of the Association of Future African Neurosurgeons. So today, I'm acknowledged and humbled on craniotomy. Okay, so we can go to our first slide.
Please hold on a second, please. It's taking a while to load.
Okay, sure.
So while this loads, we'll just have to wait a little bit. I'm not sure why it's so slow. So while waiting for this, I'd like to thank everyone who's around at the moment. Thank you for all those who supported us and have been there from the first day, especially Dr. John Bennett with Neurosurgical TV. It's been a really great experience so far. Thank you so much, guys, and we hope to do some really amazing stuff going forward.
Thank you. At the very bottom, Darwin, there's some options of the screen. At the very bottom of the screen.
I'm the one controlling. It's all right. I was waiting for it to load. Yeah. Okay. So Darwin, you can go ahead.
All right. Okay, you can give me the first, the second slide, the next slide. The next slide.
Okay. Can you see it? Where the introduction?
No, I can't see the.
Not yet. It's not. It does not change.
Wow, it's changing here, but hold on. I'll stop sharing and then start sharing again. I switched it. Has it changed?
No, not yet.
No.
Wow, this is awkward.
Yeah, I think at the bottom, Ulrich, choose one of those options to make the screen bigger. That may.
I have made the screen bigger.
Oh, okay, because we're not seeing that,
Yeah,
unfortunately.
I have. I don't know why.
Yeah, I don't know why either. It's an experiment. We can always edit this out. Don't worry.
Yeah.
Darwin, can you send me the presentation so I can see if I can share in my WhatsApp? Is it possible?
Okay. Let me try to do that.
Okay, we can see it now. Wonder if you can make. There we go. Okay, we're seeing it fine now.
Okay.
All right. Just the outline of my presentation. I'll start with the introduction, then I'll try to define craniotomy and craniotomy. Then I'll basically try to talk more about craniotomy, the indications, contraindications, preoperative care, the equipment that is used, patient preparation procedure, monitoring and follow-up, and then complications. So for the introduction, so many surgical procedures on the brain or any part of the brain require making an incision through the skull to gain access to the intracranial compartment. So we should understand that any type of surgery, most likely that will be needed to be done on the brain, will require making this particular incision into the or rather through the skull, so that you have access to the brain and other components there. So this incision that is made is either a craniotomy or a craniectomy. Now, in either case, that is both craniotomy and craniectomy are performed in the position that provides the best access to the lesion or part of the brain desired to be accessed. So it is not done at any point, let's say in the head, but it has to be done at a point that is going to offer the best access to the part of the brain that we desire to access. Okay, so just some definition. Craniotomy is a surgical removal of a section of the skull in order to access the intracranial compartment. So the portion of the skull temporarily removed is called the bone flap. So the bone flap is placed back in its original position. That is in the case of craniotomy. It is placed back in its original position after the
Hello.
operation. After the operation is done.
Darwin. We lost you for a moment. Can you start again? The last bullet point.
Okay, so I was saying craniotomy is a surgical removal of a section of the skull in order to access the intracranial compartment. So the portion of the skull that is temporarily removed is called the bone flap. Now, since we're saying that this craniotomy or even craniectomy is just the initial phase, initial step in to accessing the part of the brain that we want to operate on. So once the operation, in the case of craniotomy, once the operation is done, the bone flap is placed back in its original position. And it is typically fastened using titanium plates and screws. So for craniectomy, it is a similar procedure as craniotomy, except there are either two cases when we look at craniectomy. It's either the bone flap is not placed back at all, or rather never placed back at all, or it has to be kept for some time and then reinserted back. That is some time after the operation is done. So most of the times when we don't place it back, we have to do what is sometimes we have to do what is called the cranioplasty. Okay, so this is just we have a picture simply showing the differences between craniotomy and craniectomy. So under craniotomy there, you can see that it is usually the first part of feather brain surgery. Then the bone flap is temporarily removed. Then it is later retained in the skull after surgery. So soon after surgery is done on the brain, the bone flap is placed back. But in the case of craniectomy, it is often performed to relieve pressure on the brain. And the bone flap is surgically removed. It is not immediately put back after surgery. So not immediately, you have to put it back maybe after maybe even up to a month or so, depending on what exactly was being done. Okay, so let's look at more about on craniotomy. So the name of craniotomy being or to be done, or rather be performed, depends on the specific region of the skull where the bone is removed. So in other words, one of the classifications of craniotomy is by site or by location. That is, for example, if the craniotomy is opened in the frontal bone, it is then called frontal craniotomy. If it is opened in the parietal, temporal, occipital, or suboccipital bones, it is called a parietal, temporal, occipital, or suboccipital craniotomy, respectively. So this is one classification that we can, although I've not really outlined the classification on its own, but through the discussion, we'll be able to see that we may have different classifications, and one of them is classification by site. Okay, so then if a craniotomy involves two contiguous regions of the skull, it is named for both. So in a case where there are two regions that are being involved in the craniotomy, then the name of that craniotomy is going to be based on those two portions of the skull that are involved. So for example, if it involves the frontal and temporal bones, it is called frontotemporal craniotomy. Okay, then
hold on. Okay.
Okay, so let's look at another type, which is a very common type of craniotomy. In addition to what I've already mentioned, that is a frontal, parietal, temporal, occipital, or suboccipital craniotomies. There's another type of craniotomy called terrenal craniotomy, which is named for the pterion. Now, this pterion is the junctional point. Is the junctional point of four bones within the skull. That is the frontal, temporal, greater wing of the sphenoid, and the parietal bone. So let's look at this point, this junctional point. So when you look at the picture there, okay. So in the picture there, the second part, that is the pterion. So usually you can perform a craniotomy at that point or around that point, where the greater wing of the sphenoid bone, the parietal bone, and the temporal bone are meeting. So that one is going to be called a pterional craniotomy. Okay. Then in most elective craniotomies, so like in this case, we can have an elective, or we can also have an emergency craniotomy. So, but in the case of elective craniotomies, there is use of MRI-based navigational software. So the craniotomies these craniotomies are referred to as stereotactic craniotomies. Now, in this case, we're not saying that that term stereotactic is referring to the location, but it is simply because of the technique that is used. Now, emergent craniotomies rarely involve these MRI-based navigation software, or rather, they are rarely stereotactic. Okay. Then the other type that we have also is what is called a keyhole craniotomy. Okay, so these are small craniotomies performed in situations that that require less bone removal. So in a case where you don't want to remove so much bone, then you can perform what is called a keyhole craniotomy. Now, these keyhole craniotomies are becoming more useful with increasing accuracy of navigation software, like I've already mentioned, and advanced technique, surgical techniques and visualization. So one example of such a keyhole craniotomy is, which is minimally invasive, is the supraorbital craniotomy, which is also called eyebrow craniotomy. So in this case, the incision and bone flap are placed in the region of the patient's eyebrow. So when you look at the picture there, we can see that the bone flap is made just above the eyebrow of the patient. Okay, so this one is an example of a keyhole craniotomy. Then the smallest type of craniotomy is what is called a barrel or trephination. Now, this type of craniotomy is not really regarded as a true craniotomy, and more so as its own category of surgical approach, because it provides very limited view of the intracranial compartment. Now, like I've already mentioned, the purpose of doing this craniotomy, it's so as to have access to the intracranial compartment and the brain and other structures. Now, when you look at this bellhole craniotomy, it does not offer enough access to this intracranial compartment, and this is why it is not regarded as a true craniotomy. Now, nevertheless, with the development of the endoscope, this type of craniotomy serves as the entry point for the endoscope in many intracranial approaches. So with advance of certain techniques such as endoscopic operations on the brain, so this type of craniotomy is also becoming quite useful and common in such settings. Okay, so making the burr hole involves carefully drilling a small hole into the skull to reveal the dura mater, which can then be opened to allow further exploration on the underlying brain. So that picture is simply showing some burr holes that can be made. Okay. So let's look at indications for craniotomy. Like I mentioned, craniotomy and craniectomy, they are most the same, except in craniectomy you don't put back the bone flap almost immediately after the surgery is done. So even when you look at the indications, they're almost the same, except when we look at craniectomy, it's mostly done, especially when we have raised intracranial pressure. So, however, most of the things are similar. So, craniotomy represents the primary means by which neurosurgeons access the intracranial space. So, diseases that affect the brain and its elements, including the brain parenchyma, vasculature, meninges, and the bone, all require an opening in the skull as the initial step. So, like I mentioned as well, craniotomy and craniectomy, they are just an initial step in further surgery on the brain. So therefore, the craniotomy is the first step to accessing contents of the intracranial compartment. So that is just a picture showing just anatomy of the head, showing the skin of the scalp, the periosteum, bone skull, and the other structures, including the underlying brain and the meninges. Okay, so the indications, the following are some of the basic indications of craniotomy. So one, to resection of abnormal brain tissue such as brain tumor. So in cases of brain tumors, obviously you have to perform a craniotomy for you to be able to access that brain tumor that is there. Then also for biopsy, when you want to get biopsy of the brain tissue, craniotomy is also done. Then evacuation of hematoma such as epidural, subdural, as well as intracerebral hematoma. This craniotomy is also done. Then in microvascular decompression, such as for trigeminal neuralgia. Okay, number 5, the fifth indication, in the case of brain abscess. So if you want to drain or remove a brain abscess, then craniotomy is the way to go. To relieve intracranial pressure. Now, increased intracranial pressure. Now, this is the case where craniectomy comes into play much. So whenever you want to relieve the intracranial pressure, then usually craniectomy is done. Then to arrest intracranial hemorrhage. So in a case where you have a bleeding blood vessel within the cranium, then you have to open the cranium and arrest that bleeding. To repair or clip a cerebral aneurysm. Whether it is ruptured or not ruptured, if you want to just repair that, then you have to do a craniotomy as well. Resection of arteriovenous malformation is another indication. Then the 10th indication among those that I've listed, to repair skull fractures or damaged meninges. So in a case, let's say for example, in a case of RTA, and then we have a fractured skull. So sometimes if you want to repair the fractured skull, then you can also do a craniotomy, as well as in the case of damaged meninges. Then next we have to treat brain conditions such as epilepsy, in which the epileptogenic focus or tissue is resected. So sometimes in this case, they do what is called spherectomy and other procedures. Then insertion of brain implant such as deep brain stimulator, ventricular peritoneal shunt, such as in the case of hydrocephalus, subdural electrodes for seizure monitoring. So these are some of the indications. Of course, there may be other indications, but these are some of the indications that I came across in this presentation. Then let's look at the contraindications. Now, with contraindications, there are no specific contraindications for craniotomy itself. Okay, but a number of medical conditions may make craniotomy a high-risk intervention. So whenever you want to do a craniotomy, you have to weigh between the risks and the benefits, or rather the advantages and the disadvantages of doing that craniotomy. So the following are some of the conditions that increase the risks associated with craniotomy. Okay, so number 1, advanced age. So mostly with advanced age, we find that patients who are advanced in age, it will be more risk to do a craniotomy because of several other conditions that come in, or rather that come into play with advanced age. So we understand that with advanced age, even patients may start developing even conditions such as pulmonary diseases, cardiovascular diseases, and so on. So because of that, you find that craniotomy may become of high risk to do on patients of advanced age. Then poor functional status may also complicate craniotomy. Then severe cardiopulmonary disease, like I've already mentioned, they may also make craniotomy not to be of so much benefit. Then severe systemic collapse, which require intensive care support, such as the case of sepsis. Okay, so these are some of the contraindications that are associated with craniectomy. Okay, so let's look at preoperative care. So firstly, there should be patient education. There should be patient education and consent. So whenever you decide or discover that you need to do a craniotomy or a craniectomy on a patient, then you have to explain to the patient what you want to do, the benefits of the procedure that you want to do, as well as the risks that are associated with that procedure, and then you get the consent. Then other than that, you also have to do a pre-procedure planning, such as brain imaging, which may include head CT, CT angiography, MRI, as well as additional tests such as basic blood tests, ECG, chest radiography, depending on the patient's medical history. Because like we have said, we have those contraindications. So you have to make sure that everything about the patient is okay, and you can go ahead with the procedure that you want to do. Okay, let's look at the equipment. So when you look at equipment, it will involve the tools that are required to accomplish a standard craniotomy or craniectomy. So it is done in a controlled, sterile environment designated operating room. So although this is not so much the case with low middle income countries, where as compared to high income countries where there are these designated operating rooms specifically for neurosurgery. So in most cases, like in my country, where I'm based right now, where I'm doing my clerkship, all operations are done in the same theater: obstetrics and gynecology, general surgery, orthopedics, and so on. Urology, they are all done in the same theater. But ideally, these procedures are supposed to be done in a controlled, sterile environment, which is designated for that particular purpose. The basic objective of this procedure is to remove the bone flap as safely as possible, as well as minimize pain and blood loss, reduce potential risk for infection, and limit damage to the underlying meninges and brain. So whatever we do, we have to make sure that it is done as safely as possible. And in doing that, it means that we have to limit pain. There shouldn't be pain. There should be very less blood loss. There should be reduced risk of infection, and limited damage to the underlying meninges and brain. Otherwise, if this is not put in place, then we find that we're not going to accomplish our goal. Okay, so some of the equipments, or rather some of the instruments that are used as follows. So first we have the skin knife, which is the scalpel. Okay, so most of the times number 10 blade is typically used to make the skin incision. The suction tips and tubing for clearing blood for the surgical field, from the surgical field to maintain visibility. Then the Rene clips and tissue retractions. So these clips are placed in the scalp edges to stop bleeding, while retractors serve to keep the incision open. Then the Layla bar and fish hooks. So this is an optional setup that allows retraction of scalp and muscle for the duration of the operation, and is mostly used in terranean craniotomy. Then we also have what is called the monopolar electrosurgical unit, so which is just a cut and coagulation instrument for dissection through subcutaneous tissue, fascia, and muscle, while preserving hemostasis. Then bipolar electrosurgical unit. So we have monopolar and bipolar. So this provides focused electrocautery of blood vessels as a means of stopping bleeding, and can be used safely to coagulate the dura, to dissect both normal and abnormal brain tissue. Then you have a periosteal elevator, which is used to lift the periosteum off the skull prior to drilling. Then high-speed air drill. So this accommodates different drill bits, including bows and perforators, which are used to penetrate the skull and form a burrow, as well as the craniotome with footplate. So this the craniotome is used to cave out a bone flap. Is used to cave out a bone flap from the initial burrow. Then we have flap elevator and penfield dissector. So both both of them are used to lift the bone flap after the craniotome has drilled out a window of bone. Then lastly, on the tools that are used, we have craniotomy, min plate, and screw set. So this is a titanium low profile plating system for replacing the bone flap after intracranial surgery is completed. So like we said, craniotomy, you have to put back the bone flap. So to put it back, we have to use the titanium low profile plating system. Okay, so let's look at patient preparation. So in preparing the patient for this particular procedure, there are certain steps or certain things that have to be done before doing that. So other than the imaging and so on that have to be done, one, we have to stop, or rather to discontinue any blood thinners. Now, we know that blood thinners, if a patient is on blood thinners, then there is high risk of hemorrhage, or rather excess blood loss. So to prevent that, we have to discontinue any blood thinners that the patient is on, such as NSAIDs like aspirin and brufen, and platelet agents, and anticoagulant medication, in order to minimize blood loss during the craniotomy and the subsequent intracranial surgery. So we have to also initiate preparative steroid therapy. So usually, usually you can use dexamethasone to reduce cerebral edema due to the intracranial mass lesion, as well as anti-epileptic therapy, such as phenytoin. Okay. Other than that, we also have to put the patient on IV antibiotic administration, which is done usually about 30 minutes prior to the surgery in the operating room. So we can use cefazolin, vancomycin, or clindamycin. So the goal of doing this is simply to reduce the risk of wound infection from the neighboring bacterial skin flora. So mostly we have Staphylococcus aureus. So if we don't use these antibiotics, then we find that there'll be increased risk of the surgical site infection. So for some craniotomies, typically those involving a large mass lesion with significant underlying edema and brain shift, a diuretic such as mannitol is given during skin incision from additional brain relaxation for additional brain relaxation at a dose of 0.5 to 1 gram per kg body weight. Okay, so another thing that has to be done in patient preparation is anesthesia. Okay, so there are two broad categories that are used for craniotomy. Apologies for that typing error. That should be for, not from. Okay, so we have local anesthesia as well as the general anesthesia. But for most craniotomies, both methods of anesthesia are used. So for local anesthesia is used, or rather is injected in the incision site for superficial hemostasis and postoperative pain control. While general endotracheal anesthesia is administered for the duration of the operation. Then sometimes what is called awake craniotomy may also be done. So with awake craniotomy, the patient is active and you can interact with the patient while the procedure is being done. So I didn't go so much into details with that. Okay, then we look at positioning. How do you position the patient during this procedure? So first we look at head positioning. There are two basic ways of positioning the head. That is either unfixed or fixed. So the unfixed approach is used when rapid access is required or stabilization is not essential. While head fixation is achieved with 3 skull pins that are situated in what is called the head clamp. So the location of the craniotomy dictates where the pins are placed in the patient's skull. Then body positioning, depending on the location of the intracranial lesion, there are various methods of positioning the patient on the operating table in order to maximize visualization and improve ease access to the target. Okay. So there are 4 fundamental positions for craniotomy. That is spine, prone, lateral, and sitting. But this, you can play around with this to have others. So that picture diagram is showing some of the positions that are done. So with A and B, both of them are spine. Then C and D, that is they're both lateral. Then E there is a sitting position. So you can play around with this type of positions. Okay, then the intraoperative procedure. So I didn't really go much into the procedure itself, how it should be done. But I attached that link of some video that I came across that tries to explain the procedure, the intraoperative procedure. So once I share this slide, I hope people can follow that link and try to learn 1 or 2 things from that video presentation. Okay, so let's look at the monitoring and follow-up after the craniotomy. So we have immediate post-craniotomy care. So first you have to observe the patient for at least 24 hours. So ideally you have maybe 24 to 48 hours in the neurosurgical or the neurological intensive care unit or general surgical. Case where I am, we just have one intensive care unit where everyone requiring intensive care goes. Okay, so do basic laboratory tests for full blood count and basic metabolic panel. Then we can also have 1 to 2 hourly neurological examinations. That is usually it's done by the ICU staff. Then the ICU staff, they have to note any changes in neurological status, that is including confusion, aphasia, cranial nerve deficit, weakness, numbness, or convulsions, and so on. So these have to be noted and reported to the neurosurgeon, the treating neurosurgeon as soon as possible. Then we also have to keep the systolic blood pressure between 90 and 140 millimeters of mercury. So the reason is because pressures above this range may risk the patient for hemorrhage into the operative site, while pressures below this range may compromise and lead to possible infarcts. Then we also have to probably continue antiepileptic therapy for 24 hours post-craniotomy. Post-craniotomy or craniotomy. Okay. So although sometimes we can prolong this antiepileptic, this antibiotic therapy as well as antiepileptic therapy, depending on the condition of the patient and other factors that are there. Okay, so let's look at long-term monitoring. After the acute post-operative phase, which is 24 to 48 hours of observation in ICU, the patient is transferred to a hospital floor bed where recovery continues. So in this phase, we have to assess in the long-term monitoring, we have to assess functional demands by an assortment of therapists and plans for further care are implemented. Then removal of all dressings can be done on day 2 post-operation, and staples or sutures used to close the most superficial skin layer may also be removed by day 10 to day 5 to day 10 post-operation. Okay, so if recovery continues without any complications after discharging the patient from ICU to the hospital floor bed, and we note that recovery has continued without any complications, then the patient can be discharged as soon as day 2 or day 3 post-operation. Okay, so hospitalization can exceed this day depending on the specifics of the surgery. So it's not a mandate, or we don't have any specific period in which during which the patient should stay in hospital, but it depends on the specifics of the surgery and other factors or other medical conditions or surgical conditions that may be there. But if there are no any complications or any other factors that are there, then the patient can be discharged on day 2 or day 3. Then routine post-operation follow-up within 1 to 2 weeks after hospital discharge can be done. So this can be done even just by the patient visiting, going to the office of the attending neurosurgeon for reviews and other checkups. Then the other component, which is very important after the operation is done, is patient education. And I think this is something that is rarely done, or it should be, or if at all it is done, it has to be done appropriately to make sure that everything is continues well. So patient education is very, very important. So the patient and family should be given specific instructions on discharge as regards to the patient and anything else that may follow. So immediate call, one of the things one of the instructions that should be given to the patient or the family. The reason why the family should also be informed about these things is because there are certain things that the patient himself may not notice, but the family member may be able to notice. For example, loss of consciousness or convulsions is not always that the patient himself or herself is going to notice those, but or even behavioral changes, but a family member will be able to notice those things and may be relatable to the procedure that was done. So immediate call to the neurosurgeon should be made if the patient or the family member notes any clear leakage. That should not be and it should be any clear leakage, which should be CSF. So as we shall see under the complications, one of the complications that we may have CSF leaking from the surgical site. So if the patient or the family member notes any clear fluid leaking from the surgical site, then there should be an immediate call to the neurosurgeon and taking the patient to the facility to the facility. Then bleeding may be common in the first few days, and it may not raise so much concern unless it is very heavy, where we may anticipate or think the patient may have hemorrhagic shock and so on. But if it is minimal within the first few days, it may not raise any concerns. But if the patient notes any prolonged bleeding, even if it is not so much, because if it is prolonged and then it is over a period of time, then it can still lead to other complications. So the patient should report any prolonged bleeding from the site. Then the patient should also report any indications of wound infection. So things such as erythema on the surgical site, any past discharge, any chills, rigors, fevers, and so on. Those should be reported as well because they may indicate surgical site infection. Okay, the patient should also report anything such as nausea, vomiting, headaches, convulsions, and visual disturbances, and any other changes in neurological status. And like I mentioned, there are some of these changes that may not be noticed by the patient themselves, but a family member may be able to notice these changes, and that family member should be able to report those things to the neurosurgeon. So this is why it is very, very important to educate both the patient and the family members, especially those that are very close. Then hair products other than baby shampoo are also discouraged. Others may introduce infection on the surgical site and so on. Then the patient is also discouraged from picking and manipulating the incision. The patient should also be discouraged from flying for 1 to 4 weeks, given the possibility of exacerbating air pockets, that is pneumocephalus, that are introduced into the intracranial space during the craniotomy. So during the craniotomy, you find that air is going to go into the intracranial pressure, into the intracranial space. Now, if this patient flies, then these air pockets may be exacerbated and you have other complications. So let's look at the complications of craniotomy as well as craniectomy, like I mentioned. So being an initial step to accessing the intracranial compartment for further surgical procedures, the complications of craniotomy highly depend on and result from the type of surgery that is being performed after the craniotomy itself. So some of the complications are applied to all types of craniotomy and differ from those that result from any prolonged surgery with patients under general anesthesia. For example, these complications are going to differ from things like deep vein thrombosis, pulmonary embolism, atelectasis or pneumonia, or even myocardial infarction. So, but they're going to be related to the craniotomy itself. So the complications may broadly be classified as early complications or late complications. There may be probably other classifications, but these are the ones that I probably came across. But each of these complications, whether it is early complication or late complication, it leads to most of them, they lead to a change in neurological status. That is initially assessed with a neurological examination, followed by agent CT scan of the head. So under the early complications, some of the early complications can be bleeding or hematoma. Okay, so you may find that there's so much bleeding from the surgical site for different reasons. That's why it is important to do those basic blood tests, such as full blood count to check any if there's any thrombocytopenia and so on. Okay, so that we reduce the risk of bleeding. And we also, like I mentioned, we also have to discontinue any medications that are blood thinners. Then other complications can be seizures. Then we can also have CSF leakage, can have cerebral infarct and pneumocephalus. So like I mentioned, during the procedure, air can go into the intracranial space and cause these air pockets, or what is called pneumocephalus. Then on late complications, one of the complications is infection. So treatment of infection can be done by antibiotic therapy alone, but typically involved surgery for washout of the wound, followed by long-term antibiotic therapy. So most of the times, both of them, that is surgery and medical, can be helpful in treating these surgical site infections. Then late seizures. So an epileptic focus may form secondary to scarring, or rather what is called gliosis. So I find that after some time, maybe even up to months, then you find that the patient starts developing these seizures. So in a patient who underwent craniotomy or any surgery on the brain, if they start developing these seizures, one thing that we can think about is development of epileptic focus secondary to scarring. Okay, so in conclusion, both craniotomy and craniectomy serve to offer access to the intracranial compartment for many purposes. So like those indications that we discussed, both craniotomy and craniectomy offer access to those to the intracranial compartment. And we should note that the only difference between craniotomy and craniectomy is that with craniotomy, the bone flap is not is placed back. Craniotomy, the bone flap is placed back immediately after surgery. Then with craniectomy, the bone flap is not placed back, in which case we have to do a cranioplasty after some time, or that bone flap has to be placed back after some time, up to weeks, months, and so on. Then these can, the craniotomy may be emergency or elective. So for example, in a case of traumatic brain injury, and then we notice that maybe the patient has epidural hematoma and so on, then that kind of craniotomy that has to be done is emergency. But in cases of tumors, brain tumors, unless otherwise, but in most cases, if it is a tumor, then it is an elective procedure. And that is the case where we can even use MRI-based navigation techniques. Then the name of the craniotomy being performed would depend on the purpose. For example, you have what is called decompressive craniotomy. So it will depend on the purpose that it is serving. It also depends on the site, like we mentioned, the location as well as the size. Okay, so for location or other site, we mentioned we can have parietal, we can have frontal, we can have occipital, suboccipital, and so on. Then depending on size, we can have the keyhole, we can have a bar hole, and so on. Then this craniotomy or craniectomy has to be done as safely as possible. Okay, and in doing that, in making sure that it is done as safely as possible, we have to make sure that we minimize pain, we minimize blood loss, we minimize chances of surgical site infection, as well as minimize damage, or if anything, prevent any damage to the underlying meninges and the brain. So that's what those are some of the things that may be included in safety of doing this procedure. Then patient preparation is vital. So you have to make sure that the patient is well prepared. That includes even patient education, or explaining the procedure to the patient and getting the consent from the patient as well as the relatives, or rather the next of kin. So post-operative patient and family education as well as counseling, they are also important, and there are things that should not be omitted in these procedures. Then we have to be sure to look out for early and late complications. So those are some of my references. Thank you very much.
Great presentation altogether. Thank you so much, Darren. You did a really great job. It's a comprehensive presentation on craniotomies and craniectomies, and I think that's all there for medical students to understand and aspiring neurosurgeons. The residents will probably need a little bit more. You can find more on Neurosurgical Atlas. You can find that online. You can log in or sign up for free. Anyone has a question, suggestion?
Hello, Darwin. Really great presentation, really detailed. I think I've learned a lot about craniotomy and craniectomy. But I have a question for you. For the contraindication, what do you understand by advanced age? For you, what is the advanced age?
Okay, when we say advanced age, I think it has maybe patients above 65, somewhere there. They may be considered to be advanced age, or maybe somewhere around above 65, I think I can say so. I stand to be corrected.
I don't know, but in some countries in the world, 65 years old is still considered as being young, you know.
Okay.
But what I just wanted to say is it a relative or an absolute contraindication? Because I don't think it's an absolute contraindication, because you know sometimes you have these patients. Have you heard about normal pressure hydrocephalus? Usually happening to patients who have something like 80 years old. Yeah. So usually you have to operate the patient, because the patient is presenting with signs which will not subside if you don't do his a ventricular shunt. You understand a bit?
Yes. Okay. Okay, you can finish the question, Doc.
It's okay, Darwin. It's okay.
Okay. So like I mentioned, craniotomy as well as craniectomy does not have any specific contraindication on itself. So these contraindications that I listed, they are not absolute, but they are relative, and in most cases they come into play if they are a combination. So, for example, in a case of advanced age, it's not always that advanced age alone is going to limit this craniotomy. But if there are also other underlying factors such as severe cardiopulmonary disease, then we may find that the risks, there'll be high risks of associated with doing this craniotomy. So most of these are not absolute, but they are relative, and there are things that you can just play around, or rather, it's a matter of weighing the risks and the benefits of doing the procedure.
Thank you. And lastly, you talked about the use. We have to educate the patient on the use of hair products. I saw, like you said, it is preferable to use baby shampoo than other hair products. Please, can you explain what that part to me?
Okay, it was on patient education. That is, after the operation is done. After the operation is done, then you have to educate the patient on more like some of the do's and don'ts that they should know. So I mentioned that the patient has to be discouraged from use of other hair products like other than baby shampoo. Probably this is associated, maybe associated with risk of infection on the stage. I really think of in those lines. So I think with allergies, allergic reactions, or surgical site infections, and so on.
Okay, it's true that I don't have any idea about it. That's why I ask. Then the last, I have just a comment. You know, your presentation was very interesting. Then you arrived on the place where you were showing us the different surgical equipments that we use. I think it would have been better if you would have put images, you know, to at least illustrate what you're saying. You called many names of many tools.
Yes.
That I don't personally know, you know. So I would have been much more interesting for me to at least see what you're talking about. As I said to Zoro once, when you're doing surgery or it's just like anatomy, it's good to a little bit illustrate what you're talking about so that gives much more, I think, attraction to what you're saying.
Yeah, that's true.
So I don't know if you can complete your presentation with images of those tools, or I don't know, maybe you leave me the to complete myself, but if you can complete it and share it to us, I think I'll be happier than like that. But
Okay.
it was a great presentation. Thank you very much.
Thank you, Doc. So I think before sharing to the WhatsApp group, I'll try to put in more images. Thank you for that, Doc.
Okay. There were some really great comments and questions there. I think I can help with one of the questions about the equipment and what you can do. This is for everyone out there. If you're interested in going to the operating room, it's all you have to do. Come to this website, the Neurosurgical Atlas. You can sign up for free. You don't need to pay anything. So let me just show you guys. This is mine, for example. You can log in, and when you log in, there's even an application an app. So you have grand rounds, neuroanatomy lectures. You've got chapters as well for neurosurgery residents, and that's what I advise anyone to use. There's a whole list here. So non-technical skills in neurosurgery, for example, how should you behave? You got the medical student guide for matching, and the transition to the real world for residents and fellows. But you equally have the really more technical neurosurgery. So if you come to operative neuroanatomy, for example, you have this skull anatomy, cerebral vascular, and a whole list. So if you come here, you have everything for the equipment, their names, how to use them, how to position your patients, how to follow up your patients, what a resident is expected to do, when to do it, how to do it. You have everything. So I'll advise everyone to take the time to see this. For example, what makes a great resident? I absolutely love this. Operating room etiquette, leadership principles. So please do visit this site. You'll find everything there. When you go into craniotomy, operative anatomy, go into craniotomy, you have a whole document on the equipment as well. But I concur with Dr. Natalie. While it's good to know what's done elsewhere, you need to know what's done where you live, and you need to know the names of those equipment you use in those settings, but equally know the names of the other equipment. You did a really great job, Darwin, and we are all proud. That was amazing. You came up with some really interesting stuff.
Thank you very much, Doc.
Okay. I noticed there are a few places you weren't exactly sure maybe struggled with. I think one of them was the awake craniotomy, and the other was when you spoke about pneumocephalus in patients that have undergone a surgery and die on a plane. So what you, for the second point, what you need to remember is, so when you're going up generally, so you're flying. When you're flying, generally what happens is the pressure drops. So if you remember the formula from chemistry, pressure times volume, PV, is equal to a constant. And that constant was nRT, where N was the number of moles, R was a constant, and T was the temperature. So when you take that formula, PV is equal to a constant. So you notice that every time P drops, V has to increase. So you still get that constant. So if you're flying, the pressure drops, so the volume has to increase, right?
Yes.
Yeah. So before the patient flies, he undergoes an operation, and since you've opened that cranium, air is going to be stuck there in some of the spaces. So that air, when the patient gets on the plane and the pressure drops, it's going to increase in volume.
Okay.
And since that space now you've closed it, it's back to what it was before, but it has air now. So air constitutes a foreign body. And you remember the law of the Monroe-Kelly doctrine. It almost acts as though it was blood or maybe a tumor or anything. So it starts compressing the brain, and the patient might start showing or manifesting certain signs. So that was very good that you thought about that. I think it's one of those things that we can easily forget. We don't necessarily warn our patients about. That was interesting. About awake craniotomy. So you were describing anesthesia, local and general anesthesia. You did a great job speaking of both of them. So general anesthesia, if you want to really make it basic, what you want in general anesthesia is you want the person to be unconscious, but the fact that you're unconscious doesn't mean that you will not move and doesn't mean that you will not feel. So for example, when you're sleeping, you're not really conscious, but you move, right? You move, you turn in your bed. And if you're sleeping and someone pinches you, then you feel it. So you need a drug to make the patient unconscious or the person unconscious. You need a drug to stop the person from moving, and you need a drug to stop the person from feeling pain. So the drug that you'll be given, for example, for you to get a general anesthesia, you need those three drugs. So you need a myorelaxant, for example, or a curarizing agent that will stop you from moving. You need a narcotic to stop you from feeling pain, and you need a hypnotic kind of drug to stop you from being conscious. Now, if you're going to have an operation and it's a very sensitive area of the brain, then you need to have real-time feedback on how your operation is going and what structures you're touching. And the only way right now is to have you testing that area. So you might be operating around an area that necessitates skill it's around the area of maybe speech or singing or playing violin. So the best way to do that would be to have the patient be awake. And the patient is awake. While you're operating, you keep asking the patient to do that function. And when you see the function is altered, then you know you are close to a potent or eloquent zone. Then you need to go away from it. So how do you do this? Remember what we said about general anesthesia. If you're using general anesthesia, you knock the person unconscious, you stop the person from moving, and then you stop the person from feeling pain. So if you use general anesthesia, you can't do that kind of an operation. But the person, you need the person, for example, to be conscious, and you need the person to be moving. But you still need that person not to feel pain, right? So if you're operating and the person is, for example, playing a violin, they need to be moving and conscious so that when you tell them, can you play for me, please? And then they will do it. Or you can ask them a question in a language and then they will answer. So you need to take all those other 2 drugs away. The last drug that you're left with is the narcotic to stop the person from feeling pain. The good thing about the brain is, or neurosurgery, there are only a select few areas where you have pain receptors. You look up on that. But the obvious thing is the brain doesn't feel pain. It's funny, right? It gets the information from everywhere else, but in itself, the brain doesn't feel pain. So we'll say that for your next presentation, we'd like you to present on the pain or nociception on each of the layers that cover. So when you're living from the skin all the way down to the brain itself, parenchyma, you can take your time. It doesn't have to be next week or in next 2 weeks. So your next presentation, that will be it. So the pain receptors and nociception from the skin all the way down to the brain. This is very important because as you know, one of the subspecialties in neurosurgery is functional neurosurgery. And in functional neurosurgery, you have to deal with pain. And I mean, if you're going to deal with pain, then you need to understand how pain works in neurosurgery. And it's even more important because in the US, there's been this massive story about the opioid crisis. Patients who were getting post-operative pain medications got hooked on this medication. So it's important for you to know where the pain originates and how you can deal with this pain management. So it's also part of neurosurgery. Once again, thank you so much. It was a marvelous presentation. You're definitely shining a light on Zambian medical education, and we are happy to have you among us. Thanks.
Thank you very much, Doc.
So I think if there are no other comments or questions, we can call this a day. Okay, so thank you, John. We'll meet next week for some other presentations. Thanks.
Thank you, doctor. Doctor, one thing I didn't understood the last part that you discussed about. If the patient is general anesthesia, playing a violin and these things, how would you deal with those things?
So sorry. So you didn't understand?
Yeah, the thing that you talked about, the patient in general anesthesia and checking for the patient's like response, like playing a violin or talking to the patient.
Okay. So if you're going to use general anesthesia, no matter what you're trying to do, as an intervention, you can subdivide. This is really basic, but you can have you have 3 axes you have to maintain, you have to control. You have to control the consciousness of your patient, control the pain of the patient, and control the movements of the patient. So if you control just the consciousness of your patient will be knocked out, but your patient can still move and can still feel pain. So if the patient is feeling pain, they'll have these spinal reflexes that will make them move. And we all know when you're operating, the last thing you want is a patient that's moving around, right? So that's for an operation during which the patient is not conscious. Now, if you're going to do an awake craniotomy, the idea behind the awake craniotomy is you want real-time feedback. You want to be able to exchange with your patient. So your patient has to be conscious, because consciousness is actually being able to get stimuli from the exterior, from outside the body, and be able to respond and adjust to this stimuli. So the patient has to be conscious, and the patient has to be able to move. So in those 3 components of general anesthesia, you have to be able to have the patient conscious, so you don't knock the patient out. The patient has to be able to move, so you don't give him any myorelaxant, him or her. You don't give the patient any myorelaxant or curarizing agent, but the patient cannot feel pain. So you need to administer a pain medication only in the areas, in the layers in which the patient feels pain. So that will be the layers before you get to the brain parenchyma itself, which is from pia mater and brain parenchyma. You don't feel pain there. And that's how you have an awake craniotomy, because the patient is not knocked out. The patient can move, and you can tell the patient 2 + 4, and then the patient will be like, oh, 6, because they thought about it, they were conscious, and then they spoke, so they moved. That's how you have an awake craniotomy.
Okay, I got an idea, doctor. I thought of like in terms of like preserving the other things, we might miss like we might not be able to manage the pain. And if when the patient is awake or when the patient is conscious, he might complain us or sue us regarding these things.
Oh, if the patient is awake, you have to manage pain. You have to. You can't do awake craniotomy without managing the pain. But you need to know the areas in which you need to deal with the pain. So that will be the scalp all the way to the pachymeninges.
Yeah, it's very difficult. I thought of it because if the patient brings the hand on the head or something like that, then it will be difficult to perform the surgery.
Oh no.
Like,
The patient cannot feel pain. Then there's no way you're going to do awake craniotomy. Yeah.
yeah, and the patient should be fully cooperative adult, isn't it? It should not be.
Yeah, definitely. I mean, there's no way you're going to have an awake craniotomy with someone who has delirium, for example. There's no way you'll be able to speak with the patient. Has to be cooperative. You're right. You're absolutely right.
Thank you, doctor. Thank you. I'm clear on it.
Well, thanks.
Okay, very good. Very good. We made it through without any major technological glibs. We're off the air, by the way. Well, we're on live on YouTube, but it's not being recorded.
Okay.
You know that website, Neurosurgical Atlas, is awesome. Wow. I've never seen that. I know who he is. I know he's does a lot of videos, educational videos. But love to get him to do some lectures too. I don't know how busy he is.
So I don't know how he'd be willing to, because he has his own platform, he has his own app, his own website, and he posts videos like the same videos we do on Neurosurgical Atlas. You can always get in touch with him.
Yeah, that's whatever. But it's a good resource. It's a good, really good resource. And we're still working on our app. And Rajiv, thank you for coming. His first time here, right, Rajiv? I don't know. I think that's the first time I've ever met you.
This is my first time. I enjoyed a lot.
Yo, welcome anytime. And you're on the mailing list, right, Rajiv? Do I have your email address?
Yes, doctor.
Okay, good, because you'll be getting notices of future. We have a really good conference tomorrow with IPE again, and you're all welcome to come. And we have one from Japan on Thursday. We have Wednesday the Jordan Grand Rounds, but Thursday we have a real good one on. Let me just show you guys. I'll do my screen share now. But we have a conference from Japan. Really good presentations. Let me put it up here. With Dr. Kato. You'll hear of Dr. Kato. She's a really big educator.
Yeah, Dr. Yoko Kato. Yeah,
she's a really big educator. She put it together essentially. She works at Fujita Health University. Let me share this here, where I did a fellowship, and maybe some of you will be going to Japan for some kind of fellowship. It seems that a lot of the big neurosurgeons, that sometime during their career they went to Japan.
So if you want to do vascular neurosurgery, you have to, if you really want to be among the best, you have to at one point in your career go to Japan.
Yeah, it seems that all the biggies have been there. IPE is one of them. But these are the presentations here. We had like 7 good, looks like very good presentations, and you're all welcome to come.
Those are some really big names there.
Yeah, and Dr. Kato is a big believer in video platforms for education. So she's helping us along here, putting this together. And let's see. Well, that's about it. We're gonna edit that. We'll take out some of the major stuff, the portions. But we won't do any fine editing yet. But we're making progress, Ulrich.
Yeah, definitely. Thanks, John. Thank you.
Yeah, I'm coming up to Boston. Unfortunately, I won't have time to come up there to Boston. I'll come up to Rhode Island on Tuesday.
Yeah, you told me for Thanksgiving, right?
Yeah. I'm going to see my brother and hopefully do some business too when I'm up there with some people that are interested in the Spanish channel, developing that. So thanks everybody for coming. I'm going to head off.
Thank you.
And
Thank you.
everyone
Bye-bye.
have a great day.
Thank you.
Thank you, Nathalie. Great presentation. Darwin, great. Thank you.
Thank you, John.
Thank you for putting the time in. You guys put a lot of time into that.
Thank you, Doc.
I can't believe it. You put a lot. You had to put a lot of time in that. And Zolo, I'll be talking to you soon. Okay.
All right, Dr. Ben.
Okay, and we'll get the promotional aspect of this thing cranked up.
Okay.
Okay, and you can teach me about Facebook, how we can use Facebook a little bit better.
Okay, Doctor.
Okay, adieu, everyone.
Bye.
Bye-bye.
Bye.